this project aimed at paramedics and EMTs in the state of Washington. We are probably the 10th county that this has been rolled out to now.
Probably like the 23rd county.
The 23rd
total.
County. We're the slow county there. And so she's going to have you excitingly take a test to start with, and then we have a pre-test and a post-test.
You don't look excited.
No, you don't look excited. But I'll let Patty tell you more about the project and get into this whole plan.
Perfect. Good. Hi everyone, my name's Patty. Can you hear me on the microphone? Okay, perfect. My name's Patty Downey. I'm from Harborview's Incident Prevention and Research Department, or HIPRC. We're in the third year of our project. It's a pilot project that's funded by the DSHS. What they did was about 4 years ago, they went out and did a survey of the national guidelines as well as our state guidelines for TBI protocol. Washington State showed that we didn't have a lot of really clear guidelines for TBI protocol among all of the 39 counties in Washington State. So DSHS contacted us and requested that we create a pilot project that outlined what the national TBI protocols were as well as the Washington State TBI protocols were, and then do a quality improvement pilot project. And so how that works is we have a first part of it is we contacted your county and we requested about 20 PCRs from your county. They go through an internal audit at our department at HIPRC, where we're looking at all the assessments and treatments of a possible TBI call. And then I come out to the county. I provide an hour-long training, which is what we're doing today. And then 6 months down the road, I'm going to contact your county again and ask for another 20 PCRs that are related to TBI. We're going to put them right through the exact same audit and see if there's any quality improvement. And we're doing that in all 39 counties in Washington State. We've already completed 23 counties with multiple trainings. I have worked for HIPRC for about 4 months. Prior to me, it was Giles Gifford, and I work alongside Dr. Vavilala and Dr. Deepak, who are anesthesiologists at Harborview. Along with that, I also work for AMR in Seattle, so I've worked on an ambulance for the past 6 years, so I have been in the field and have experience with that as well. And as Dr. Whitworth said, we are going to start with a test today. So it's a 10-question test. It's anonymous, so don't worry about it. You don't have to put your name on it. All I request is that you put your level of training and your county that you're from. You're going to get to take this test again at the end, so you get a second chance, so don't worry. You look bad. Okay, guys, how was that? Easy? Yeah. You're going to take it again at the end. It's anonymous. And at the end, we're going to do the same test over again. And at the on the back of that test, there'll be a review, so you guys can review this whole lecture. If there's any suggestions that you have, any complaints that you have. We also take positive reinforcement. So one of the reasons DSHS contacted us, we can talk about this, is we were realizing if you look at cardiovascular emergencies where they were about 10 years ago, we are about there with TBIs right now. And so we're trying to get everybody up on the protocol and the guidelines and what they can do in the field. I've looked over your county's protocol, and there's some counties that I go to and I talk to the doctor, the MPD once. I contact him and I get the okay to come to the county, train in the county, and then I never talk to him again. In this county, I contacted your doctor, Dr. Whitworth. He made me come down and have breakfast with him this morning, talk to him about my protocols and send him the outline of the protocols first. He told me that you guys were all going to be here. Sometimes I show up and there's only like 5 or 7 people in the room, and then and they say there was more coming. So I just want to thank you guys all for coming, and it's really nice to see a county that's so organized, that all comes together at least monthly. I also went over your protocols, and your protocols were really thorough. There were a couple of discrepancies in your protocols that we're going to talk about, just with hyperventilation, just to get everybody on the same page. The other thing that is a big deal is that we're finding that for TBI, the long-term outcome of patients that suffer traumatic brain injury, EMS responders are the most important chain in that link, because the first several hours of that patient's treatment is going to be crucial to their long-term recovery. So whether you're diagnosing this patient's GCS or you're bringing this patient in diagnosed with a traumatic brain injury or and what level of GCS they are on, or whether you're initiating airlift, if you can initiate airlift in this call, or how you're treating that patient in transport, and whether you're continuing your assessment so that you're getting proper diagnosis for that patient in the field. So if I move too fast, or if I go too slow, or if I'm not talking loud enough, just let me know. A lot of this is going to be really, and I'm going to apologize ahead of time because your guys' protocol is so up to date and because you guys are so organized, a lot of this is going to be really repetitive for you. We're going to talk about documentation, we're going to talk about assessment of GCS, we're going to talk about hyperventilation, and just treating and assessment of TBI patients. And most of you in the room, I believe, are medics, so you guys should all be on board on this, and not a lot of this should be new. So we'll get started. So some basic epidemiology in Washington State. 10% of all injury-related TBIs result in hospitalization. 26,000 residents in Washington State per year suffer TBI. Of those, not the majority of those are actually even reported. So we also have several other research projects going on at HIPRC. One of them being pre-hospital, as well as in the hospital, and well as long-term treatment for TBI patients, one being like high school TBI patients. The second, number one, we could all guess, would be football for high school kids. Number two is girls soccer for secondary for second injury for TBI. So 5,500 hospitalizations, 1,300 deaths per year. Of those 5,500 hospitalizations per year, 1 in 5 patients will never return home. So of those 1 in 5 patients that you take into the hospital, they will become dependent on the state or on a family member. That means out of the 5,500, 1,100 patients per year will not return home. Who's at risk? So of course the elderly are at risk. They're the highest at risk. Ages 15 to 24 are high risk, and male gender. So if your age is 15 to 24 and you're of the male gender, you're 3 times more likely to suffer a TBI than a female. So thank God everybody's over the age of 24 in the room, I think. So 1 in 3 adults over the ages of 65 will fall each year, and 1 in 2 over the ages of 80. And these are the statistics that were given to us by the Traumatic Brain Foundation. With our growing baby boomer population, this number is going to rise. So we're going to have a lot more elderly, and a lot more falls, and a lot more TBIs per year that you're going to be dealing with. And again, 1 in 5 people who are hospitalized for falls will never return home. There's 2 types of TBI, right? There's primary and there's secondary. And what we're focusing on here is the secondary TBI, because that's what we can manage once we've gotten to that patient. So the primary is what happens prior to us actually even arriving on scene, the impact. And the secondary is what's going to happen in the next couple of hours, the next 24 hours, 48 hours after that patient's initial impact. And those are the things that we can watch for, assess in the field, and we can treat in the field. And that's going to improve the outcome of that patient. These are some of those secondary TBIs that we can look for and treat: intracranial hypertension, ICP, as well as hypoxia, so that's decreased oxygen to the brain. We have hypotension, which is decreased blood to the brain, which is going to affect oxygen and glucose to the brain. And then hypercarbia, which is if you're not breathing, you're building up in CO2. You're not blowing off CO2. Some basic signs and symptoms. So if there's BLS in the room, this is some basic stuff that you can recognize if you don't have the capabilities of ETCO2 readings and such, or EKG. So signs: diminished consciousness, convulsions and seizures. Dilation of one or both pupils is a big indicator of ICP. Slurred speech, repeated vomiting and nausea, increased confusion, restlessness, or agitation. And then some symptoms that a patient might give to you are headache, blurred vision, ringing in the ears, bad taste in the mouth. I haven't actually had anyone in all the counties that I've trained in say they've had a patient that's ever complained of bad taste in mouth. Ringing in the ears, yes, not bad taste in mouth. So if anybody has that one, come tell me, please. Weakness or numbness in extremities, loss of coordination, dizziness, and lightheadedness are all symptoms that your patient might tell you that they're experiencing for TBI. Scene awareness. So one of the things that they're really pushing through the National Brain Foundation and in the hospitals is scene awareness, as well as documentation of what's going on in your scene. And I've been working in Seattle for 6 years, and I've written a ton of reports. And this is the first time that I've had to read a ton of reports. We request 20 PCRs from every single county, and then 20 after the actual training. So I've read hundreds and hundreds of reports, and I will tell you that I've learned a lot about writing reports from reading reports. If any of you guys have experienced that, is that I infer a lot about what everybody else knows about what's going on scene. So it's really, really important that we're painting a really, really, really clear picture. Your scene awareness is exactly what the provider is going to know in the hospital, and only what the provider will know in the hospital. So if you don't put it down on paper, everything that goes on scene, everything that you witness on scene, everything that the witnesses witness on scene, it's not going to get mentioned back at the hospital or be related back to the hospital. So your initial impression, how was the patient found? So did you find the patient down? How did you find the patient? Were they unconscious? Were they alone? Were they inside? Were they outside? If they fell, what did they fall on? Events occurring pre and post injury. So what happened? This one's really important. I find this a lot reading the MVCs, is there's not a lot of documentation of what happened prior to the MVC. What was going on in the car, and why was there a car wreck? So it's really important that if you have any witnesses on scene, that they might be able to relay that information to you if that's available. Kinematics leading up to the injury. So this one should be really repetitive for everyone. We should all know this. MVC: speed, restraints, intrusion, helmet. So were they restrained? Was there airbag deployment? How fast was the vehicle going? What did the vehicle hit? Did it hit another moving vehicle? Did it run off the road? Why did it run off the road? I was just in the county, Stevens County yesterday, and they are all equipped on every ambulance with cameras. And I know that, I don't know if you guys get cameras on your ambulances, but I know that we all have phones. So a lot of people from my county, they'll get out of the car, their partner will take a picture of what's actually going on scene to document for the nurse or the doctor. You're not allowed? Of the vehicle? Not license plate, but the intrusion on the vehicle, if possible. Or else you can have your partner document what's happened to the vehicle. So a lot of times people have their partner jump out of the car and document where the vehicle was hit, what side of the vehicle was hit, and where your patient was in the vehicle is really important. So was your patient in the front? Were they driving? Were they in back? Assault, so head versus object and repeat assault. So if your patient is assaulted by somebody else, how were they assaulted? Were they assaulted from the front, from behind? Were they assaulted by one person or multiple people? What were they assaulted with? Were they assaulted with fists or baseball bats? And were they down on the ground? Were they kicked in the head, in the front of the head, or in the back of the head? This is all really important information that you can relate to your provider. And I know it doesn't sound important sometimes, but it's really important. And if you might know this on scene, but it is not. We don't know this in the hospital. So make sure that you're documenting it in your paperwork. And a fall. I just read a report the other day, and the report stated patient fell downstairs. And that was it. So how many stairs did the patient fall down? What kind of surface did they fall onto? Were they inside and they fell on carpet, or were they outside and they fell on concrete? Did they fall forwards or did they fall backwards? Why did they fall? Important information. So just make sure that we're, like I know that everybody is trying to document as best they can. I document as best as I can, but sometimes I forget that it's not a very clear picture if I don't put it in there, and that a lot of it is just in my brain and I'm inferring it onto the paperwork, that they're going to understand what's going on scene. So make sure it's a really, really clear picture. Witness accounts of the patient's behavior before the injury, especially in the nursing facilities. If you're in the nursing facilities, I find this a lot, is you might want to ask the baseline prior to the actual injury. So if you're getting an elderly patient with a TBI, possible TBI, and they're confused, the GCS of 12, is that their natural baseline? Do they know what day it is usually? Do they know who the president is usually? And that's something that you can ask any of the nursing staff. Hopefully they will know. We all know that they might not know, but hopefully you can get that information from the roommate or the nursing staff or whoever's available to you at that time, so that you can relay that information to the doctor or put it in your report that this patient might be confused, but their natural state is already confused, and they're a little bit more confused than normal, or that they're not confused and they're completely with it and they're 95 years old and now they're confused and this is not their normal state. Witness accounts, so again, witness accounts behavior. Also in the nursing facilities, make sure that it's witnessed and not inferred by the nursing staff at the facilities. That happens a lot. As well as, if there is witnesses, please document witnesses, because there's always a lot of times there's somebody on scene, and if there's not a witness on scene, or there's nobody there to tell you what the events were prior, why did this person fall down, or why did they have this accident, write down there was no witness account, so that we know that you're asking the questions. And I know that you're asking the questions just like we all ask the question for LOC, but if it doesn't happen, sometimes we don't write it down. So if there's no loss of consciousness, a lot of times I won't see it in the report, even though I know that the question is being asked. But since there was no loss of consciousness, they didn't document no loss of consciousness. So make sure you're doing both so that in the hospitals they're not just assuming that you didn't ask the question. Specific items to document include some repetitiveness here, mechanism of injury, loss of consciousness again, if it did happen or if it didn't happen. Ask your patient, do you remember all the events leading up to the injury? If the patient states they remember all the events leading up to the injury, put that in your document so we know the question was asked of your patient, or if there's a witness on scene that states there was no loss of consciousness, make sure you put that into your report. Serial vital signs. One thing that the National Brain Association is requesting for vital signs, and this is the golden standard, is that we take vitals and transport every 5 minutes versus every 10 minutes. And I know that sometimes that can be difficult, especially if you're dealing with a severe trauma. The real hope here is that for TBI patients that will be able to push, if we're pushing for 5 minutes, we're going to fall in the timeline between 5 and 10 minutes versus if we're going for the standard 10 minutes, you fall in between 10 and 15 or 15 and 20. So if you can push for 5 minutes, hopefully we'll get closer to that number. We're also going to talk about why that's really important, especially with hypoxic patients. Another really important reason for your guys' documentation is that this documentation is going to follow that patient for the rest of their lives, not just into the hospital to that initial ER visit, but it's going to follow them when they later on down the road ask for physical therapy from their insurance company. And they're going to refer back to your paperwork and see what happened on scene and see if it's validated for PT or long-term treatment. So make sure the quality of care, your documentation, your assessment is all linked to the quality of care long-term for that patient. Anybody have any questions about that? A lot of repetitiveness? Okay. Airway priorities, of course, determine the airway is open and maintain patency. Assess need for artificial airway. Reassess again. They're requesting every 5 minutes that you reassess the artificial airway. Maintain cervical C-spine precautions. If you don't use a C-spine precaution for a TBI, document why you justified not to use a C-spine precaution for a TBI patient. Another thing that we have to think about when we have a TBI patient or anything that's a trauma, it's a fall or MVC or assault. One thing that I'm looking at in reports, so when I ask your county for their reports, I'm asking for anything that's related, not necessarily diagnosed or not necessarily chief complaint a TBI, but anything that could possibly be a TBI patient. So anything that could possibly be a TBI patient, there should be serial vital signs in there that you guys are checking, pupils and GCS, to see if this patient is possibly deteriorating while you're in transport, because any patient that has any kind of MVC or fall or assault could possibly deteriorate and become a TBI patient in transport. So even though your chief complaint might not be that, all those things should be in the report when I check for when I do the audit on that report. So breathing and oxygenation, assess rhythm, depth, rate, quality, and effectiveness. So ventilations, if possible, use continuous SpO2 monitoring, which is very effective. Avoid inadvertent hyperventilation, and we're going to talk about that. We're going to talk about hyperventilation as well as hyperventilation and why we don't want to pre-hyperventilate. Reassess every 5 minutes. If no SpO2 is available, there's signs and symptoms that we can look for. You guys all have SpO2 available to you here? And everybody have ETCO2 readings available as well? Great, great. So if you are BLS and you don't have SpO2 available to you, these are some of the signs that you can look for in your patient. Blue and dusky mucus, impaired judgment, confusion, decreased LOC, tachycardia, which is a heart rate of greater than 100, tachypnea, which is respirations greater than 20, and cyanosis in fingernails. One reason it's really great that we have SpO2 readings is because a lot of these signs and symptoms are similar to shock. And so if you have an SpO2 reading, we can tell whether it's shock or it's a decreased SpO2 reading of less than 90%, and you can treat for both. So patients with hypoxemia, one of the good, really important reasons that we do serial vital signs every 5 minutes is that national studies show that patients with TBI that suffer hypoxemia, their mortality rate increases, as well as they experience transient hypoxic states. So they are not hypoxic 100% of the time. They're dropping below 90% saturation, off and on throughout their assessment and treatment. So if you're doing serial assessments every 5 minutes, it's more likely that you're going to catch that patient as hypoxic and that you can treat for that patient hypoxemia, get them up to 100% O2, and then you're going to increase their outcome, their likeliness of survival. So you have a direct impact on their care and their long-term outcome by treating for hypoxemia. Hypotension, so another side effect of intracranial pressure. Hypotension, any patient that suffers hypotension in transport or during assessment or post their primary TBI, it multiplies by 2 their death likeliness of dying from their TBI incident. So any patient that drops below a systolic blood pressure of 90 is twice as likely to die from their initial injury. And one of the reasons why primary injury is not a good tell for this patient's long-term outcome is because most patients, 1 out of 3 patients that is going to die from a TBI is going to be walking and talking to you prior to their death. So that initial injury, whatever it looks like, is not going to be a good tell of how that patient's long-term outcome is going to be, because they're going to be walking and talking to you 1 out of 3 before they die of that actual injury. So monitor for hypertension may indicate raised intracranial pressure when associated with bradycardia. Again, Cushing's triad. We're all familiar with bradycardia, hypertension, and irregular respirations for the Cushing's triad 3. Assess, again, systolic blood pressure every 5 minutes. Circulation. So here's the shock side of that, which shows up a lot like hypoxemia. A lot of the same symptoms. You have tachycardia, tachypnea, hypotension, or skin cyanosis. One of the tells, narrowed pulse pressure, which is a difference of less than 25 between the diastolic and the systolic BP. Another thing that they're really pushing, and I don't know if you guys push this out here. I know that we all learned it in our initial training, is the GCS, the Glasgow scale. It's in the pamphlet that we handed out. And the reason for this is because serial readings of the GCS scale is going to be a really good tell of how your patient is doing or how they're maintaining, if they're staying stable or if they're deteriorating. So you can tell if they're a GCS of 15 and if they drop by 2. It's also going to be able to give a good picture to the hospital when you get to the hospital, to the doctors, of how your patient's maintaining. And it's also going to be a good tell for you if they're deteriorating, because there might not be any indicators physically that are telling you that the patient's deteriorating, but if you're monitoring the GCS, you might be able to catch that deterioration or that there's swelling going on in the brain because they're deteriorating. So, of course, follow your ABCs before you do the GCS. If possible, assess GCS prior to intubation. Measure GCS before administering sedatives. I'll keep in mind, so it's all patient preference every 5 minutes. GCS attained by direct patient interaction. So I know that a lot of people test for the mentation by asking your patient to grab your finger and squeeze. One of the reasons why this is not a good way to tell is because babies under the age of 6 months, it's a natural reflex. If you put your finger in their hand, they're going to automatically squeeze your finger. After 6 months, if the baby continues to squeeze your finger as a natural reflex, there's a possible brain defect. So if you're dealing with an adult that's at their basic brain level and you ask them just to squeeze your finger, it might not be a good or accurate tell of their mentation. So what I like to ask my patients in the field, and what I've had other people tell me or do in the field, is they ask their patients to touch all their fingers to their thumb. And that means that they understand what I'm telling them, they're able to interpret, and they're able to physically complete that demand for me. So just squeezing the finger is no longer a good. And you can get whatever it is that you want them to do or whatever works for you, but you need to make sure that you're interacting with your patient and then you're getting a good idea that they're able to actually perform the task easier than just squeezing the finger or elicit something. If eyes opening and does not occur to voice, use auxiliary pinch or fingernail nail bed pressure. GCS, another reason why it's really important is because there's some really good tells on the GCS scale for possible cerebral herniation. So eyes opening, 4, spontaneous, 2 or 3 to command, 2 to pain, and 1 number our best motor response. So this is the way that I didn't learn the GCS this way. Other people have learned it. I learned it 4 6-5, which doesn't seem in order. It's not in order to me, and it made it harder to learn. It doesn't matter which way that you put the GCS in order or how it works for you, as long as if the GCS is less than 15 when you're rating your patient, that you specify where the patient is deteriorating, in what category is your patient deterioration. So if the eyes are only to pain, that you put E2, motor 6, and if he's only responding in inappropriate words, then you would put V3. And so that I know, you know, and the doctors know where your patient's deteriorating, and then you can continue to measure that if it changes in transport or at the hospital. Best motor response. Verbal is a 6, localizes to pain. So if you put an IV on board or you do an auxiliary pinch and that patient reaches over and grabs wherever where you're hurting them, that's higher on the GCS scale, so that's a 5. If you put an IV in and that patient just pulls away, that means they have less mentation going on, and it's lower on the GCS scale, that's a 3 or a 4. And then we have the last, or these two, which is flexion and extension, which are really good tells. So flexion is a 3. So if somebody is in like this, and extension is down here like this, and it is a 2 on the GCS scale, it is a very good indicator that your patient has intracranial pressure and that possible cerebral herniation is in the next few moments. When we talk about the GCS table or the GCS scoring, if you look at this patient right here and you look at her below the waist, she presents exactly the same, but it's a different score on the GCS table. And the GCS table was created to rate and assess a patient from above the waist because of the two differences between extension and flexion being a big indicator for TBI patients and intracranial pressure going on. Verbal response, orientated. Disorientated is a 4. Inappropriate words, inappropriate sounds, and no response. On the GCS scale, so a 14 to 15 would be a mild TBI patient and could go to your local hospital, wherever you guys take your patients around here. 9 to 13 would be moderate, and then a 3 to 8 would be a severe TBI, and we'd need to go to a level 1 trauma center, which would be Harborview. And the lowest score that your patient can get on the GCS, any patient can ever get, is a 3. Anybody have any questions on that? No? Okay. So again, flexion and extension are really good tells. So if your patient is in extension, fists out, then one of the signs of possible cerebral herniation or impending cerebral herniation, and we're going to talk about watching for one of that sign and then possibly treating with hyperventilation. So GCS value provides basis for determining the method of transport to prefer what facility. If you're continuing this evaluation in your transport, you might be able to catch that this patient is now deteriorated from a 15 to a 10 and needs to go to a level 1 trauma center. Compare to previous scores to identify trend over time. This is going to help. You're going to be able to see how your patient deteriorates in the ambulance very easily, but if you're not creating a clear picture for your provider that's going to meet you at the hospital, they're not going to be able to see that deterioration. So this is a really good way to provide that picture, a clear picture for your provider or the doctor at the hospital that's going to meet you of how your patient's deteriorating in the field. Repeated GCS scores, deterioration of 2 or greater points is a bad sign. So if your patient's a GCS of 9 and it deteriorates by 7, your patient's going down the, or deteriorates by 2 to a 7, your patient's going down the drain. So every county changes for intubation. So I've heard people intubate their patients. I've heard 8 intubate. The standard, the national guidelines, is 9 intubate they ask for. I've heard people say that they like to secure the airway quickly, and they will intubate at 11. Also keep in consideration when you intubate your patient, you're going to raise the intracranial pressure. So if you have a possible TBI patient and you want to secure that airway early, to make sure that you're in control of that, and they're only at an 11 or a 12, that you're taking in consideration that you might also be driving up their intracranial pressure and causing other problems down the road. But it's personal preference, again, or whatever your MPD in your county recommends, or your protocols. So eyes, this is something that I always see in reports a lot, but I only see 1 of these. And this is a really good tell for a patient that doesn't have any trauma, exterior trauma, that might tell you whether there's pressure going on inside and should be done repetitively every 5 minutes, and it's really, really easy for us to do. Pupillary size and the reaction to light should be used in the field and can be helpful in diagnosis and treatment of a patient, especially if you're a BLS provider and you don't have other resources to use. Checking pupils is really quick and really easy. Fixed and dilated pupil. So a fixed and dilated pupil is anything that's less than 1 millimeter of reaction to a bright light. Warning sign, and it can indicate impending cerebral herniation. Pupillary size and reactivity should be measured after the patient has been stabilized and reassessed again every 5 minutes. So we have unilateral and bilateral dilated pupils. So asymmetric pupil is one pupil that is greater than the other pupil by 1 millimeter. Dilated and fixed is anything that is less than 1 millimeter of reaction to a bright light, and that is a good indicator. So asymmetric or fixed and dilated are both good indicators of cerebral herniation and we can watch for, and then we can treat in the field with temporary hyperventilation, and we're going to talk about that when we get to it. So what happens? What's causing the dilation? So when there's pressure in the brain, it's pressing down on the intracranial nerve. That can be going on during your transport. So why you can catch this is as that pressure is building in the brain and it starts to press down on that intracranial nerve that controls the dilation of that pupil. So easy thing to catch. Other things that might cause dilated pupils or irregular abnormal pupils, hypoxia, of course, drug use, orbital trauma, pharmacology, hypotension, artificial eye. So make sure you're checking with your patient, or another good reason to talk to a witness if you're checking pupils and your patient's unconscious is if they have abnormal pupils. What does all this mean? So we're assessing for possible signs of impending cerebral herniation, something that we can also, along with hypotension, hypoxia, cerebral herniation is something that we can watch for and try to treat in the field prior to them getting to the hospital. So an unresponsive patient, so no eye opening or verbal response, unilateral or bilateral dilated or asymmetric pupil, again, 1 millimeter, no reaction to light is fixed, 1 millimeter greater than the other is asymmetric. Abnormal extension, arms out, or no motor response to painful stimuli. So you can have a patient that is unconscious and unresponsive, severe TBI, but not in possible impending cerebral herniation. So they don't have any other signs and symptoms. They've just knocked themselves out. And you might have some pressure going on, but we don't have any other signs and symptoms occurring right now. These specific signs and symptoms are going to be tells to you that your patient's, the pressure in your patient's brain is building, and that you can treat this with a treatment in the field to prevent that pressure from turning into a herniation. So deteriorating neurologic examination, bradycardia. Hypertension should be viewed as part of the Cushing's response and implies impending herniation. So once you've reached this stage of Cushing's triad, there's 3 stages to the Cushing's triad. This is the last stage of the Cushing's triad, so swelling is already occurring. They're already going through some symptoms. The first stage being tachycardia and hypertension. The second stage being bradycardia and hypertension. And then the final stage, which is impending cerebral herniation within the next couple of moments, is hypertension, bradycardia, and irregular respirations. And you should be treating for cerebral herniation at that point. So additional considerations, patients with illness, injury can have signs and symptoms similar. So another reason, documentation, we're just talking about this before we actually had this training, is that we all, if you're a big county, we all have repetitive people that go in and out of the hospital every single day or every week that we all know by name, the hospital knows by name. ETOH we use as the code word for alcohol or drugs on board in Seattle, because we're not supposed to say patient has been drinking, unless we witness the actual alcohol on scene. A really important reason for this is that we have patients that drink a lot. If they fall and there's no alcohol on scene, you want to put that in your report so that that assumption is not made by the providers in the hospital, that this is a TBI patient. And when you were on scene, you did not witness any alcohol or drugs. Witnesses on scene stated he was not drinking, that this is a TBI patient. Also, another thing, besides people that are repetitive in the hospital and on your ambulances, is documenting this regardless of whether there's alcohol and drugs on scene. So we always document when we know that there's alcohol on scene or this patient's been drinking. Document it when there's no signs of alcohol on scene. When you know this patient has not been using drugs, it's really good, because then the hospital can't make any of their own guesses in the hospital about why they crashed their car, why are they 16 and they wrecked their car. So make sure that you document that as well. Decreased mental status and previous medical conditions. So these are all good reasons why you take a history. Protect C-spine, alignment with manual inline stabilization, beware of facial trauma. So these are the priorities. This is repetitiveness. Maintain airway patency administer O2, possible monitor SpO2. I'll go over again, so serial SpO2 readings every 5 minutes if you can. If you guys are doing it on computers, write it down and then put it in later. Provide combi tube or supraglottic airway, if not certified. Advanced airway adjuncts. Indications for intubation, again, is the GCS binational standards of 9 or less. Rapid sequence intubation. Intubate medications are doses per discretion. I believe it's lidocaine out here for patients possible with TBI. When to intubate, secure airway. So GCS of less than 9, a patient that's unconscious with a GCS of less than 9, unable to maintain their own airway, or an SpO2 of less than 90%, so hypoxic. Respiratory failure or apnea, you want to just intubate this patient and normal ventilate at 12 respirations per minute. That's a respiration every 5 seconds. So intubate and normal ventilate 12 breaths per minute, again, every 5 seconds. If pupils are symmetric, reactive, accompanied by localization, and withdrawals or flexion. Intubate and hyperventilate, which is a respiration every 3 seconds per minute. If pupils are asymmetric, so they differ in 1 millimeter, if dilated and fixed, if accompanied by extensor posturing or flaccid. So that flaccid has to be, if your patient's just unconscious and flaccid, it has to be accompanied with some other signs. Consider signs of herniation. The motor components of GCX exam is used to determine the signs of cerebral herniation. So if your patient deteriorates from conscious to unconscious, that might be a good indicator that your patient is declining. Why capnography? So in your guys' protocol here, which I believe has been changed. So the national guidelines, Washington State guidelines for TBI patients, capnography, why it's so important and so useful that this county is using capnography is that you can hyperventilate your patient within some certain guidelines, and you can ventilate your patient within some certain guidelines. So when you ventilate a patient, normal ventilate at 12 respirations per minute, we try to keep that patient's EtCO2 readings between 35 and 40. When you hyperventilate a patient at 20 respirations per minute, you want to keep that EtCO2 reading between 30 and 34. And we'll talk about why that is. You want to do serial readings of your EtCO2 reading. Jot those down multiple times so that doctor can have that, so I can read that, and so that you know if the patient is deteriorating or that you're staying within those guidelines. Assess and record rate, rhythm, and depth and quality. Determine effectiveness. Respirations post-intubation. Assist ventilations as necessary with BVM, supplemental O2. Adults normal ventilate respirations is a rate of 10 to 12 again. Ventilate and maintain SpO2 above 90%, so something that we can treat, hypoxia above 90% in the field. Patients with normal TBI, unconscious, no other signs and symptoms, you want to normal ventilate again. So this is, and we're just getting really repetitive on this because we're going to talk about what happens when we hyperventilate a patient and why it's only a temporizing measure. So patients with TBI who are unconscious and unresponsive intubate and normal ventilate. Patients with TBI and suspected brain herniation, which are those signs and symptoms that we just covered, you want to hyperventilate at 20 respirations per minute. Hyperventilation is a temporizing treatment. So you will assess your patients with TBI that are unconscious and presenting with these signs, and then you hyperventilate them at 20 respirations while these signs are presenting. You want to keep them in an EtCO2 reading of between 30 and 34. When those signs and symptoms start to decline, you stop hyperventilating your patient and return to regular respirations at 12 respirations per minute. And the reasons for this is that when you hyperventilate a patient, you drive up their O2 and drive down their CO2, and that changes the basicity or the pH balance in their body. It also creates a vasoconstriction, which decreases the blood to the brain. So the hope is that when your patient is possibly going to have a cerebral herniation, pushing the brain past that bony structure, if you can hyperventilate that patient, you're going to decrease the blood to the brain, which is going to pull back on that pressure that's building in the brain for that amount of time until those signs and symptoms recede. But you're at the same time while you're doing that, you're decreasing oxygen to the brain. So this is why we don't hyperventilate prior to those signs and symptoms, and we don't continue to hyperventilate. We only do it for a short amount of time while those signs and symptoms are present and when those signs and symptoms are present, because we do not want to continually decrease oxygen to the brain. Also, if you're pushing a patient's pH balance up, so it's one reason we stay within really strict guidelines is average pH balance is between 7.34 or 7.35 and 7.45. Anything above 8 pH leads to coma and death, and anything below 7 leads to coma and death. So it's really strict guidelines that we're staying within because it's a very sensitive treatment that we're giving our patient. And you can continually monitor your ETCO2 readings while you're intubating and hyperventilating this patient. Also, if you're in really rural areas, you might have to do this multiple times in transport. So your patient might continually present with some of those signs and symptoms that you have to hyperventilate until they reside, and then continue normal ventilation. Also, make sure that you document if you're hyperventilating your patient, as well as document if you're normal ventilating your patient. So if you're ventilating, if you've intubated your patient, write in your paperwork that you're ventilating and assisting your patients in respirations at 12 respirations per minute. So prophylactic, it's preventative. Again, no preventative hyperventilation. So if your patient is not presenting, don't hyperventilate your patient, and do not drive your patient's ETCO2 readings below 30. We want to keep them between 30 and 34 with hyperventilation, between 35 and 40 with normal ventilations. So after end-tidal CO2, use ETCO2, confirm endotracheal tube placement. So of course, check your ETCO2s after you've intubated your patient. Measure adequacy of ventilation, target range, again, 35 to 40. Guided hyperventilation therapy, hyperventilation is 30 to 34. Respirations is 20 for hyperventilations, respirations per minute. Severe hyperventilation is a reading ETCO2 of less than 30, and we do not want to get less than 30 for your ETCO2 readings. Less than 25 is really bad. So avoid hypotension. Again, if your patient experiences hypotension, a TBI patient with hypotension, it doubles their likeliness of morbidity. So you want to make sure that you're monitoring for systolic blood pressure less than 90 continually with your patients and keeping that blood pressure up. Administer isotonic crystalloid solutions to maintain systolic blood pressure in normal range. Use dextrose-free isotonic fluids. Right now in the field, we're only using isotonics and not hypertonics. So normal saline or lactated ringers. Administer isotonic fluids to maintain, again, the SBP of 90. Treat for shock as opposed to restricting fluids. Always treat with gas. So primary treatment is if your patient's sick, you want to make sure that you get going and you're on the road and then get those IVs started. This changes in every county. So up in the northwest counties, when I first started teaching this, I said that intravenous was the primary preference, and I got a big rise out of the crowd. So intravenous was a huge preference up there, and I'm not sure why that difference from county to county. It's personal preference. So preferred percutaneous access site if you can. If you're moving fast and you need to do interosseous, or you're a patient that doesn't have good access, you can do interosseous in the field. Cerebral herniation, so additional considerations for possible cerebral herniations when you're treating your patient is agitation and combativeness. So the environment can affect your patient's intracranial pressure and then lead to cerebral herniation. Optimize patient transport by using short-acting sedatives. Some of these treatments may cause hypotension, so you might want to make sure that you're considering the hemodynamic state. Rule out decreased level of consciousness due to hypoglycemia. So every county, every TBI patient, you guys can do glucose checks. Every patient that comes in the hospital should have a glucose check. It's a really easy assessment and treatment that we can check in the field and that we can do in the field to treat our patients, give our patients better treatment, to give a better outline to the hospital providers when we get there. So I don't see it a lot in the reports, and it's sporadic from county to county. So make sure that every patient that's a possible TBI, you're getting a glucose check in there before you get to the hospital. Cerebral herniation signs and symptoms again. Dilated or unreactive pupils, asymmetric pupils, a motor exam that identifies either extensive posturing or flaccid, no response. Progressive neurologic deterioration of GCS of 9, deteriorating by 2 on the GCS scale. Other factors increasing intracranial pressure, again, is your environment, patient's agitation. When you intubate your patients, you're going to increase the intracranial pressure. That's why we use lidocaine for possible ICP patients. Airway suctioning is also going to increase the intracranial pressure. Does anybody have any questions on these signs and symptoms? No? Okay. So mannitol, one drug that they use in the hospitals, is a hypertonic and it pulls fluid off the brain. We don't use it in the field yet. We use isotonics. You guys use isotonics down here in your county as well. They're still controversial for in the field use. And then lidocaine is another controversial drug that we use prior to intracranial intubation for ICP patients or TBI patients because it's believed to have a blunting effect which slows down the heart rate so that you don't drive up the intracranial pressure when you intubate a patient. There's no negative reports on lidocaine. It's just there's not been long-term studies with a lot of data to confirm the outcomes of patients that have lidocaine versus patients that don't use lidocaine. But everybody that I've talked to and everybody that I know that works in the field and all the doctors back lidocaine or believe in it pretty strongly. So transport decisions. Can you guys activate trauma code or airlift in the field? You can. Okay. So minimize pre-hospital time by selecting the appropriate mode of transportation. If you're doing a continuous GCS scales, you should be able to determine whether this patient needs to go to your local hospital, to a trauma center, or to a level 1 trauma center, and then initiating that in the field. Or if you know that the airlift is going to be out longer than it takes you to get to the local hospital for a higher level of care, writing that in your documentation. So this patient is severe TBI, initiated either trauma code or to rendezvous with airlift at the hospital or to rendezvous with airlift, initiated airlift in the field. It's good to put in your report so we know that that's going on and that they're getting quick help. And that way that they can not make any assumptions at Harborview and call you guys up and try to give you crap because it's right in the report. Patient may require emergent surgery for hematoma evacuation, so this is why it's really important if that pressure is going on that they go to a level 1 trauma center. Improved success attributed to interrogation of pre-hospital and hospital care access. So the faster they get to that level 1 or the appropriate care, the faster that you guys are diagnosing and giving them proper treatment and then getting them to the proper care facility, the better their outcome is and the less likely that they're going to be, or the more likely they're going to be able to return home after they're treated in the hospital. So, and these are the scoring for the GCS, and this is why serial GCS are so important, and taking GCS is really important because it's going to help you determine what level of care that they need to go to, especially if they initially present with a GCS of 13 and then they start deteriorating while you're en route and you catch it. So a GCS of 14 to 15 is going to go to the hospital, local hospital. GCS of 9 to 13 to trauma center, and anything below 9 and below is going to go, is severe, and it's going to go to a level 1 trauma center, so Harborview in Seattle. Patients with severe TBI, and the reason why they go to a level 1 trauma center is because they have a neurosurgeon on staff 24 hours a day, CT scanning available, also ability to monitor intracranial pressure and the ability to treat intracranial hypertension. So a lot of the hospitals as well will have, the non-level ones will have an on-call neurosurgeon, but Harborview has one at the facility at all times. And that's it. It's really quick. Yeah, I went through it really fast. There's no questions. Do you guys have any questions? Did it feel really, don't go anywhere, did it feel really repetitive? You feel like you guys already know all of this stuff? It was really good. Okay, so we're going to do another test. It's the exact same test. On the back of it is a review. We're going to go over the answers to this test so that we're all on the same page at the end and we all understand what this was about. And then I'm going to also go over the audit tool at the end. And the audit tool is just going to tell you what we're looking for in the assessments when they come into the into HIPRC, and so what we're scoring you guys on, so you have an idea. Okay, so second one, it has the review on the back, so you can go ahead and give a consciousness. Dilated pupils, convulsions, diminished consciousness, lower extremities, weakness, blurred vision, all of the above, or none of the above? None of the above. E. So, number 2, hypoxia and hypotension are recognizable and preventable causes of secondary brain injury. True. Tachypnea, tachycardia, changes in level of consciousness, and cyanosis are all signs of shock, but not hypoxemia. False. Right. The motor components of the GCS focus only on the upper extremities. True. True. What is the GCS score for a patient whose eyes open to pain, withdraws from painful stimuli, and makes inappropriate sounds? 8. Right. C. That would have been C. Squeeze my hand counts as obeying a verbal command. False. It is not a verbal command. Prophylactic, preventative hyperventilation should be initiated for every severe TBI patient. False. So only if there's certain signs and symptoms presenting that are cerebral herniation indicators that you do hyperventilation. Patients present with extensor posturing, fixed dilated pupils, and SpO2 of less than 90%, EMT should intubate and hyperventilate. Correct. A. I had to look at that one, sorry. All of the following are signs and symptoms of cerebral herniation except we have dilated pupils, extensor posturing, cyanosis of the fingernails, or Cushing's triad. Cyanosis, so that's C. Patients with severe TBI should be transported to a facility with immediately available CT scanning, prompt neurosurgical care, the ability to monitor ICP, 2 of the above or all of the above? All of the above. And I was just informed that you guys don't transport to Harborview. Got it. Okay. Fair enough. And that's why it's a good idea for like the reviews on the back, because you can give me that information. And we're here to make, the primary purpose of this is definitely for us research and some quality improvement, but it's also so that we become better providers in Washington State. We're number 1 for cardio right now, recovery, so we would like to be number 1 for TBI. And by doing that, it's just by working together and getting information back from you guys, because you guys all have different things that you deal with out here that we don't deal with in Seattle. And so any information that you give me is good information, and I'll take it back to my boss. So, and then after that, we have the audit that is the last page on your packet. And we'll go over that real quick. So again, if it's a suspected TBI patient, if it's possible that this patient could have some kind of pressure going on, although they're not presenting, then you just think they've got neck pain or they've got a bruised knee, but they were in a car accident. There should be all these assessments should all be in your report, because you should be checking to see if they possibly become a TBI patient. So it's 1 through 20 for ALS providers and 1 through 15 for BLS providers. We have different categories of BLS providers in Washington State. So we also have, Washington State has BLS providers that can intubate as well as start IVs. So those providers are counted as ALS providers. So we check and see if you're rural, if you're ALS or BLS, chief complaint on scene, because it might not be a TBI, but might turn into a TBI. Age, gender, medical history, and medications, if you can get those, if your patient's conscious, of course. Where we start grading is in the documentation. So thorough record of mechanism of injury. Did you tell me everything that happened that you got from the witness or that you witnessed on scene? Events prior to, if you could get any of that information. If there was no witnesses or nobody to tell you what happened prior to on scene, that you document that there was no witnesses or that there was nobody to tell you what happened prior to on scene. If the fall, how far did they fall? How did they fall? Pedestrian versus vehicle, all of these things. So if you specify how the injury actually happened. Initial impression of TBI. So the initial impression when you walk on scene, how is that patient presenting to you? Are they confused? Are they unconscious? Are they coherent? Are they walking to you and talking to you? Level of consciousness, their mentation, and their behavior. Did you list their initial signs and symptoms and the obvious wounds? Loss of consciousness. Did you document whether there was loss of consciousness, or did you document whether there wasn't loss of consciousness? Patient states they do remember all events leading up to. Witnesses say there was no loss of consciousness, or patient states they do not remember all the events, or there was a blackout or brownout or whatever they call it. Or it was not documented at all. And at that point, if you don't document it at all, then you get a minus, a deduction. Complaint. So the next part is assessment and neurological exam. Completed vital signs, so serial vital signs every 5 minutes. We look at time on the ambulance. How long were you on the ambulance? I try not to take into consideration how long you're on scene, because usually we're doing a lot of other things on scene besides taking vital signs. So the time on the ambulance between the initial transport and the time that you reach the facility that you're taking that patient to, how long was that, and was there multiple vital signs in that time that's allotted to you? So respirations, did you document how many respirations? Did you document whether you hyperventilated this patient? And if you breathed for this patient, did you document whether you were breathing at 12 respirations or 20 respirations per minute? O2 sats, serial O2 sats, systolic blood pressure, and the pulse rate. Was this reassessed vital signs every 5 minutes? Yes, no, or not documented? GCS, was this GCS 9 to 12, 13 to 15, or was it not documented at all? Was it GCS components parts? So if you have a GCS of 15, GCS 15, move on. Reassess 5 minutes later. GCS 15, move on. If you have a GCS of less than 15, you want to document in your report the specific areas and where your patient's deteriorating. So I will be looking for, if it's GCS of anything less than 15, eyes, verbal, or motor, and to make sure there's a specification in each of those categories so we know where your patient's deteriorating. Reassess vital signs every 5 minutes. Oh, sorry, went backwards. Reassess GCS every 5 minutes. Pupils examined. So did they examine the pupils? Hopefully we're doing examinations every 5 minutes. If you do those every 5 minutes to check for possible pressure that's occurring inside your patient's brain. Also, documentation of both the right and the left pupil, that you're documenting that you checked both right and left pupil. Reassess pupils every 5 minutes. ETOH or alcohol, drugs on board. Did you document that there was drugs and alcohol on board? Did you document that there was no drugs and alcohol, that there was no signs of possible drugs and alcohol on board or at scene, or not documented at all, which you would get a deduction for? C-spine immobilization, yes. No, if you did not, make sure that you specify what your justification was for not C-spine immobilization. Oxygen, yes or no. Amount. And then right below here, suspicion of hypoxemia, or no suspicion, and I would go through your assessment and see if any or all of these signs showed up in your assessment. Tracheal intubation indications, and this is where we get passed off from ALS or from BLS to ALS, and we rate you if you're ALS versus BLS. So GCS, tracheal intubation indications if the GCS is less than 9, inadequate airway or SpO2 of less than 90, or apnea. No for GCS greater than 9, secured airway, SpO2 greater than 90%, and they're breathing on their own, or if it's not documented at all. So here would be the ALS grading, which would be capnography. Used after you intubated your patient, yes or no? Did you do a reading, and did you do serial readings, multiple readings? How many? 1, 2, 3. Post-tracheal intubation, respiratory rate documented. So are you breathing for your patient? If you're intubating your patient, how many respirations per minute are you breathing for your patient? ET ventilation rate, yes or no? So hyperventilation at 20 respirations per minute. Asymmetrical, and here's some of the signs and symptoms that you're looking for hyperventilation, which would be asymmetrical pupils, dilated pupils, GCS motor exam, extensor posturing, or flaccid, and GCS motor exam scores of 5 and 6, so deterioration from a 9 by 2 on the GCS score. Normal ventilate, 12 respirations per minute, ET CO2 reading of 35 to 40. It's a symmetric and reactive pupils, localization, withdrawals from flexion, response, and a GCS motor scores 2, 3, and 4. But you're writing all those down, 2, 3, and 4. IV initiation, did you document it? TKO, fluid administration type, what kind of fluids did you use? And was the systolic blood pressure less than 90? And then for BLS and ALS on all reports, there should be a GCS or a glucose reading on all of those reports. So everybody should be able to do that. And then down below, which would be transport, transport to the appropriate facility. Where did you take this patient? What type of level of facility did you take them to? So document what type of facility and why, level 1. And did you do the appropriate mode? Did you transport ground, priority, routine, or did you initiate airlift? And that is it. So hopefully all those things are making it into your report. Hopefully this was helpful and not just repetitive information. And that's all. That's all I got for you. What? Question? You know, I don't know. That I guess that depends on how your papers document. So whatever we get is your PCRs, your field reports, and that's what I'm assessing. I'm not getting your EKG readings if that's in the EKG report. Anybody else have any more questions? Can you get that electron? You want a copy of that? Sure, sure. I can send it to Dr. Mark. And
Any more questions?
okay. That it?
All right. Thank you.
Thank you, guys.
We have have another 20 minutes or so to go, so why don't you take a little break, get some coffee, check your head injury scores. Case reviews to do that are kind of germane to some of the things that are going on. Does anybody have any questions about the, you guys already picked up on the fact that that Ms. Downey is primarily oriented to Harborview, and that, she actually thought that airlift came down into Clark County and took people to Harborview. So, that's not uncommon. It's kind of the egocentric theory of Harborview and being the only level 1 allowed in the state, and level 1s are not. Level 1s are under the American College of Surgeons. A level 1 trauma hospital is no different now than a level 2, except, yeah. Well, Galileo did prove some of that stuff, yeah. But even the Pope has turned out to be not infallible. If the Pope can resign, anything can happen, right? Okay, first case. 49-year-old male struck by a mid-sized car while crossing 4th plane. Moderate damage noted to front of vehicle and windshield, and patient boot was noted to be 75 to 85 feet from where he was found. So, supine on the road, conscious alert times person and events, strong odor of, remember, alcohol-like beverage noted on patient. What does alcohol smell like? Yeah, it does. Let's face it. It smells like alcohol. So that's kind of that's the old-fashioned thing. The lawyers say, "Oh, you can't say, I smelled alcohol." And it goes, "What does alcohol smell like?" And I said, "Well, it depends on what kind of alcohol." But all smell. If it smelled like beer, put it down. It smells like beer. Anxious, cooperative, obvious discomfort noted. Laceration noted to occiput. Deformity noted to right humerus. Open tib fib noted to right lower leg. Okay, here's some vitals. So first vital. Well, first of all, his GCS initially is 7. Okay, but then rechecked almost immediately. Within 5 minutes, and actually doing a decent scoring, it's 12. Pulse rate's 110, respiration 20, vascular access, IV, 1,000 cc bag was hung, but it notes that ultimately only 150 cc, it says 150,000, but it's 150 period 000 cc is given, and he was started on the ALPS study was started because his blood pressure was 76. Not ALPS, but the ROC study. They don't mean ALPS; they mean the hyporesus study. So ROC study, it should say. Then his blood pressure is 80. Patient position supine, radial pulse at 90. Total amount of fluid volume given was between 150 cc's and 250 cc's. So this was a hyporesus patient who initially started out with the GCS less than the allowable, but probably was inaccurate. And on the so the second assessment, he was found to be GCS of 12 and hypotensive. So trauma team activation. He ended up with anterior tib fib fracture, open fracture, anterior shoulder dislocation, elbow and facial abrasions, and blood alcohol of only 0.1, which is probably one of the lowest we've seen in a long time. And He and the hospital maintained him on the hyporesus procedure, so he was one of our now 4 entries into hyporesus. Next one is 27-year-old male stabbed by girlfriend's brother, he says. Pain in left shoulder and left arm feels numb. Says the knife went in about 6 inches. Denied shortness of breath, back pain, midline neck pain. Patient sitting on the floor, blood-soaked shirt, alert, small puncture wound in the left shoulder clavicle area, a hematoma developing in the neck and shoulder area, no other obvious injuries found. Okay, initially, GCS, of course, is 15. Reports, quote, feeling weak. Now, note, 222. Pain scales 10. Hysterical patient begging not to die. Pupils are equal. That's a good thing to note. We were looking at at one of the handouts, which has a thing called Homans on there. If you look at that, and Homans is a fixed dilated pupil on one side, not due to head injury. Homans pupil is usually due to neck injury because you get the recurring branch of the sympathetic chain that goes to, it's either the 3rd or 4th cranial nerve, I can't remember which one. And the same thing can happen with a stab to it or a direct blow to it. And it's either a sluggish or a non-reactive dilated pupil on one side, and you know it's nothing wrong with the patient because the patient's sitting there conscious, alert, and talking to you. So that's not a, but that's a, so it's good to know whether the pupils are okay when somebody gets stabbed in the neck kind of area. Pulse oximetry is okay. Vascular access is obtained, and notice that I don't find any blood pressure available. I think this guy was so squirrely and hysteric that I think there was some issue about his stability in general. Started an IV with 1,000 cc's. Didn't use any. Or actually total about 100 cc's. His, somewhere here I missed a blood pressure. 85, yeah, 80 palpable. So he also was entered into the blood pressure's 80, diastolic palp. He also was entered. And it kept having difficulty to palpate blood pressure with ambulance movement, etc. So, but he was transported to he had 50 a ROC study was started. It says ROC ALP study. It's not ALPS, but 50 cc's intravenously given. Total fluid volume, I think, was 250 cc's. His blood pressure is 120 diastolic palp after that little bit of fluid. And he also was entered into the study. He had a stab wound, left subclavicular fossa, got his left subclavian artery, so potentially could be a major bleed, but turned out not. They did an IND, sutured the subclavian artery, and he was stable enough to discharge the next day. So, 2 entries, and nice thing about these were not low-level ground level falls. Dallas has entered a whole bunch of people into the hyporesuscitation study. It turns out that they're throwing out almost all of them because they were almost all ground level falls in old people who had low blood pressures to start with. So it kind of skews the thing. So at least none of these ground level falls here. Whether these people had significant injury or not is an interesting question. They did meet the criteria, and here are the criteria. Blunt or penetrating injury with a pre-hospital, at any point, a pre-hospital systolic blood pressure of less than 90 or less. Age greater than 18 years of age, excluding severe blunt or penetrating head injury with a GCS of less than 8. Now, I think that first one was a little spurious. It was 7, but I think it was probably, you know, occasioned more by the alcohol and by, you know, the initial presentation of getting run over by a car and whacking around that he had he probably, if you recounted it, probably wouldn't be a GCS of under 8. I think the GCS has to stay head injured, excluding, of course, bilateral paralysis if you gave more than 250 cc's of fluid. So currently, Vancouver Fire, I believe, has 250 cc bags now. They trucked them out from Rock Central. District 6 is supposed to be getting them. I talked to them last week, so they're on board. Good. So everybody should have the most everybody who's going to be first response should have the available. When you see a trauma and you think, oh, this could be a potential for a rock entry in hyporesus, you know you can't enter them if you give them more than 250 cc's. Now, you can monitor your bag, your 1,000 cc bag, very closely, or smart money is to put the 250 cc bag on that patient in case they will become eligible for rock, and then we don't overshoot on the fluid. You can't enter them into the study if the CPR is going on. That person, you'll enter into the ALP study probably if they've got VFib. Known prisoners, the usual suspects, known prisoners, suspected pregnancy, drowning or asphyxia due to hanging, greater than 20% burns, and time from dispatch I'm not even going to worry about. Okay, so here's the basic protocol. Blunt or penetrating trauma. What I'd like you to do is start doing patient vitals and assessment as you're starting the IV. Put a 250 cc bag on if it's available. If not, really just keep it at TKO. Even if you've got 250 cc bag, keep it TKO until you decide if the patient's going to be entered. The patient's entered with those criteria. They're excluded if they don't fit the criteria for entry. Then just follow the local protocol. You notice that head injured patient, because one of the things she's talking about that Ms. Downey was talking about today is that we don't keep significantly head injured patients, i.e. 8 or less GCS. We don't keep them hypotensive. We try to get them closer to normotensive because they're not hypotensive from their head injury. They're hypotensive from body injury and hypovolemia or whatever, and they need to have enough pressure to drive to get cerebral flow. So they're automatically out. They go into the regular arm. Okay, so if you decide that they meet criteria, you open the kit. Then you'll find out happily whether it's a 1,000 cc bag in there or whether it's 2 little 250 cc's. Document the time the kit is open, the systolic blood pressure, presence of radial pulse. Either one will get you the count. But you use the same thing over and over. If you documented absent radial pulse, you then measure your result by the presence of a radial pulse. If you documented hypotension by blood pressure, even if you palpated the blood pressure, you continue to follow the patient by blood pressure. Okay, any questions about that? Okay, you list the amount of fluid given before the study started, which is nice if you only have a 250 cc bag. Now, if you open it, you have 250 cc bags, you still have to change out to the study fluid, even if you've got a 250 cc bag hanging. because we're counting those bags. So you start the study bag, time the study fluid is started, and if they're less than 70 systolic blood pressure or no radial pulse, you give them a bolus of 250 cc's. Reassess. If they're still less than that or no radial pulse, you give them the other one. Reassess. If they're still less than that, then you have to grab one of the 250 cc bags out of the AMR. AMR should have 250 cc bags ready to go, you know, a couple of extra ones. Now, that hasn't happened yet, but it will happen if things work out correctly. Now, if it's the 1,000 cc bag, you just, and their blood pressure is less than 90, you just continue to bolus them however much you want until you get above 90. Okay, you get about, you know, about 100 to 110 systolic blood pressure. If it goes over 110, just TKO it at that point. So that's easy. That just follows your normal protocol. Okay. So any questions? These are the 4 cases that were entered. People documented quite well. There's a little bit of variance, but it's not bad. I mean, considering that that these pop up so infrequently, it's amazing. We got like 4 in a row over a period of about a month. Now, granted, they weren't really high impact ones. The second one had a really potential. Actually, both of them had a potential to be serious. It turned out not to be so bad. I mean, I've seen subclavian artery laceration bleed out. I mean, to the point of dead. So, I mean, that is a potentially bad injury. Happily, didn't turn out to be that bad. Okay. Now, a little different one. I'm going to follow this one. 84-year-old male, pulseless and apneic, daughter who may have had some mental disability. Related, she found patient in the bathroom, not breathing, unsure when he was last seen. History of diabetes, heart disease, not clear on recent medical history. AMR is on the scene. This is taken. Some of this information taken off the fire thing, obviously. AMR on the scene. Remove patient from the bathroom, is performing CPR on kitchen floor, and beginning the ACLS process. Patient was pulseless, apneic, skin warm, dry, and pale. Dextrose was 164, ETCO2 49. Okay, look at the times now. 10:17, chest compression for cardiac arrest. 10:17, pale, cool, dry. 10:17, vital sign, no blood pressure, no respirations, etc. Kind of dead. Assisted ventilations, bag valve. 10:19, so 2 minutes of CPR. 10:19, defibrillation number 1. VFib, well, when the ROC people read our report, particularly the AMR report, as you write this using the computer assist, it says ventricular, shock, ventricular fibrillation to ventricular fibrillation. And I keep telling them that doesn't mean you're peeking to see what happened right off. That just is the way the computer program writes this thing. And I don't like it, but that's the way it is. So, at any rate, so defibrillation 1 at 10:19. At 10:22, defibrillation 2. At 10:23, blood glucose. At 10:23, vascular access. So it's a little slow on the vascular access here, but okay. So we got what? 10:17 to 10:23. That's 6 minutes. Okay. Gave some fluids. 10:24, defib number 3. Epinephrine given. 10:24, ROC ALP study. 10:26, shock number 4, 1026. Okay, capnography, ETCO2, waveform result normal, and 58. Intubation, confirmed with waveform, 1027, lung sound, okay. 1028, defibrillation 5. Rocks, so now the second rock is given. Now we're looking at, so the second rock is given at 1028. We started at 1027, so we got it, so 28 to 17 to 27 is 11 minutes. More epinephrines given, and then I guess we had nothing else to do. Think about it then. So we gave some mag. Why not? We're still going. So, and oh look, 1038, shock 6. Allegedly VTAC. And then they do CPR, and 2 minutes later, the patient has a normal sinus rhythm. And starts hypothermia protocol. Got 300 cc's of cold fluid on the way. Blood pressure is 120 palp, pulse rate 100. Capnography is now at 38. They did a 12 lead, no STEMI suspected on the 12 lead. Capnography 33. Handed off to the ED. So we've got 17 minutes, or 17 to ROSC essentially at 10:38. So we've got of that amount of time, 21 minutes of CPR and 6 shocks and all the rock drugs and magnesium. Why not? And so what do you think the outcome of this patient is? Has severe 3-vessel disease, but the arrest was not thought to be due to coronary syndrome. He had the 3-vessel disease fixed. Remained in hypothermic protocol, weaned from sedation, woke up, seemed normal. His normal function was discharged with a modified Rankin scale of 0 to 1, which means we can't tell any difference from when he came in, and went to the SNF for rehab care because, well, there was some question that his daughter was the ideal place to go for continued care. I mean, so this is a really good case. What we want to talk about, though, is the timing. And I know that you got to be there to know how it goes. So okay. So the ALPS inclusion criteria, as you all know, is non-traumatic out-of-hospital cardiac arrest with vascular access with either an IV or an IO. Now, we got an IV in, but in this one, it was 6 or 7 minutes after you got there. And kind of my rule, if you can, is that you get a minute to find an IV. I mean, a good rule, a minute to find an IV site. If you don't have an IV site, drill them. That's what we gave you those wonderful Makitas for. And then the patient has to be persistent or recurring VFib, VTAC after 1 or more shock. You can't use any open-label amiodarone or any open-label lidocaine prior to getting them into the study. And once they get in the study, you can't use any open-label lidocaine or amiodarone unless you break a bottle, unless you break one of the ALPS kits, and you have to, and then the patient's automatically out of the study. You still have to tell us that you entered it in the study, but broke a bottle. Now, that doesn't mean, and I'm going to be suspicious if a lot of people come in with broken bottles and say, I had to put them into take them out of the study. Same protected population. You can't take prisoners, can't take children, pregnant persons, etc., or people with a no study bracelet. Has anybody seen a no study bracelet yet? There's just not many of them out here. What counts as a shock? Any shock that's given by a genuine bona fide AED, or any shock that's given by a paramedic or EMT, AED, or actual defibrillator. So if the first responders gave an AED shock, or if the bystanders pulled an AED off the wall and the AED gave a shock, that's still the first shock. AEDs don't lie. Ball don't lie, AED don't lie. The only thing that doesn't count as a shock is if the guy's ICD goes off and he says, oh, it's been firing all day. Too bad. That doesn't count as a shock. Persistent recurring VFib or VTAC is confirmed VFib. VFib, VTAC, shocked by an AED, shocked by a paramedic. Pulseless, meaning needing CPR. Anytime after the first shock, that is if it recurs as VFib, if the machine says shock again the second time, that is recurring VFib. So that counts. Now the patient we just talked about should have got the first ALPS drug probably after shock 2 and not after shock 3. It's a little late starting into that one. If you think antidysrhythmic drug for VFib or pulses VTAC, think the ALPS kits now. And that's what the orders say. Think ALPS kits. Only 17% of the codes are recurring VFib. Study drugs, we'd like to get them as soon as possible. We keep saying, and Modia has always said, oh, we'd like to see them in within 10 to 12 minutes of starting. He's kind of fudging. He likes to see them in even quicker than that. We'd like to get them in ASAP, to the point that you'd probably like to start thinking about if you have the manpower to do it, when you give the first dose of epinephrine, think about giving the first dose of ALPS drug at the same time, or maybe even before. Just flush the tubing. If you give the epinephrine first, you have to flush the tubing before you give the ALPS drug. Now, if you cannot, now, if you give the epinephrine after the first shock, then I would not give, you haven't proven recurring VFib until you see the second view. So, but anytime you know you're going to give that, if you know after 2 shots, if you don't give the epinephrine until after the second shock, then you should probably think about giving the ALPS kit at the same time, in that same sequence. Now, granted, it requires some, you have to have personnel available. 2 people can't be doing this. It's the way it works. If VFib, VTAC returns, you carry out the full ALPS procedure. The full ALPS procedure is syringe 1A and 1B, and then if they continue to have, and it's the next view. If after getting that, and they end up with still in VFib, and you shock them, you can give syringe number 2 at that point. You don't have to wait 15 minutes, 10 minutes. You give it right as soon as you get it. So if you gave syringe 1A and 1B, and you got ROSC, and then the patient goes back into VFib, then you shock and give the second dose of rock med at that point. ALPS med. And then you can give more epinephrine after that too. So late recurring VFib, VTAC, if you've already stabilized the patient, you're traveling, and they weren't in recurring VFib, VTAC, they had one episode of VFib, you shocked them, they came out of it, you're stabilized, you're in the back of the rig, you're driving in, you're almost at the hospital, and the patient goes back into VFib, shock them again, and give them the first dose of ALPS med, because now you've got recurring VFib. So anytime VFib, VTAC returns after one or more prior shocks, give the ALPS drug. So, unless the patient's really little, it's 2 syringes for the first dose, 1 syringe for the second dose. In this case, after you gave all the study drug, you can use magnesium, and that's it, as an additional antidysrhythmic. Now, do we know whether the magnesium made any difference in this case? I have no idea, but it's better than, well, we don't know. But the point is no open label amio, no open label lidocaine. Even if they recurred late on this, let's say you did the whole thing, you got ROC back after giving all the drug, package the patient, and you truck them on down to the hospital, and once again, they go into VFib, VTAC. When you're halfway to the hospital, you shock them again, continue CPR, and you can give them magnesium at that point, but you can't say, oh, I need to give an antidysrhythmic drug. You can't use amiodarone, you can't use lidocaine. If you break a syringe, they're automatically excluded, but you have to let us know that you entered the patient, because it comes out of it has to be figured into the documentation. You have to use the clear link adapter. There are 3 of them usually in that kit, so if you drop one, kick one out of the rig, grind it up under pure anger. Things work. Once you get used to them, they work okay. It just has to be, it requires a little finesse and a little carefulness. You have to use them because those syringes are not compatible otherwise. Put the ClearLink adapter on the IV tubing first, then attach the syringe with about a half a turn, and that takes care of it. Here's the number, which is written down in the kit, so you can call. And you get a real person now. Well, almost real. And then, but you call because we have to let the family or the patients know that they were enrolled as soon as possible. That's the federal requirement. And of course, you'll also turn in the little, this patient has been entered into the ALP study, tell the nurse, give them the little piece of paper, and the hospital has to know they were in the ALP study. Document, which you normally do, document whose monitor was used, and then the CPR process file from that monitor will ultimately end up at the ROC study. If you can, timestamp each dose, time note each dose, and you have to include the study drug kit barcode. We've had 32, 33 enrollments from Clark County. Most of them have been perfect. We've had a couple documentation issues. We've had a couple of Kongs, kit open not given, because they thought they were in recurring VFib, or when they opened the kit, by the time they got the patient was either back in, where it was in a PEA with a rhythm, or had already been had an ROSC. So, all right. Next month, I think, is endocrinology. Fun and games. We'll try to wake you up.